Thanks very much. Hi, everyone. So thought I'd start off with where is BNSSG? So Bristol, North Somerset, South Gloucestershire. That's where we are, so down in the southwest there. And if you didn't know where we are right now, and I love little animations, that's where we are. So yeah, it's about 2 hours south for us going home today. So what I'm going to be talking about is some modelling work that we've been doing, some long-term forecasting. And I need to start by explaining the Cambridge Multimorbidity Score. But if anyone was either at Anita's keynote talk yesterday or the slot before this, again from the Health Foundation with Anne Raymond, this is hopefully familiar. So this is like a recap. So what is the Cambridge Multimorbidity Score? So it's 37 common morbidities, and it was designed specifically for the purpose that we're using this for. So that's why it's our metric of choice. And one thing to say is that it's an additive metric. So any diagnosed condition you have, if you have one condition and then you have another one, you add up your scores to get your overall thing. Some examples of the Cambridge Multimorbidity Score in action. So hearing loss gives you a weighting of 0.07, so that's not very big. Anxiety and depression, if you get diagnosed with that, an extra 0.47. Cancer, quite big at 1.5. Not that this is a quiz, but can anyone remember what the largest morbidity was? Dementia at 2.47, yeah, so we've got 37 of these. We actually use 30 in our model through this, and this is how it works. To just go through this, quickly talk about individuals. That's one thing that I'm very aware, and we do constantly think about as well, is that we are thinking about individuals in our modeling. We're not, when we think about things on aggregate, obviously these are individual people we're talking about. So if someone, say we've got Christopher in our population, age 39 with 0 conditions, his Cambridge Multimorbidity Score is 0, right? So everyone starts on a baseline of 0. If we have people with different ones, so hypertension, asthma, IBS, liver disease, what happens? You add up the scores for each of those diagnosed conditions to get a score of 1.19. And then a final persona, because I run out of little clip art people, although this one's quite nice, go painting. If we have these conditions, so you see bowel cancer there, any cancer gives you definition, Cambridge Multimorbidity 1.5, add them all up, you get 3.1. What do we do within BNSSG? So in our ICB, we can calculate the Cambridge Multimorbidity Score for every adult in our population. So we have around 750,000 adults. We've calculated the diagnosed Cambridge Multimorbidity Score. And then we've segmented it using a population segmentation model into 5 different core segments. This is what we call them. So the first one at the top, core segment 1, so this is the people with the lowest diagnosed illness, and it takes about half the population. So most of the population, 52%, have a Cambridge Multimorbidity Score of under 0.09, and the annual spend per person in terms of healthcare utilization is £300. And then the way that we design these cutoffs in terms of thinking about the CMS score is as such that this property popped out. Now, this didn't have to happen. It's just a feature of our data in our population, is we have a halving of population size as you go up the cohort of the segments, and we have a doubling of mean annual spend per person. So if we just do an example of core segment 2, you can see that people in that group, there's about 25% of the population, so half as many as core segment 1, but the average healthcare spend per person is roughly double, and we go all the way through. Looking at our personas, how do we do that? So what we can do is we can get everyone's individual score, and then we can put them into one of these 5 bins in terms of core segmentation. And as I've already said, this was exactly what Anita was talking about yesterday. We're using the same score underlying our model, and I'll talk about that when we get to the model. And just to think of this in terms of the 3 segments, the way that the Health Foundation think of this, so either no illness, so that was Chris with absolutely 0 diagnosed illness, Susan would have some illness, and Isaac would have major illness. So it's using the same metric, but think about it in slightly different ways of partitioning our data. So that's all well and good. That's the background theory to now talk about the dynamic population model that we've created and run. So the approach, there are 2 stages to this. The first thing is to project the number of patients in each health state. So that's our 5 core segments. So what we do is we have really good data on the current population. So we look at how many people are in each core segment. And then we also look at how they're transitioning between segments on average. So we know that core segment 1 patients, we know the percentage chance that they're going to move to core segment 2 in a year based on our data. So that's the kind of BNSSG, that's the data that we hold in the ICB. And then we add on to that the ONS population projections. There are subnational population projections. In fact, this is exactly the same as the Health Foundation model, the same underlying data. And I'll talk later about future work we're doing using these models, and there are other models in this space as well. Everyone so far that I've seen is using the same underlying ONS subnational population projection when they do this. So what we get from here is we can get our population projections, not just numbers of people, but numbers of people in each health state out to 2040. And we can do this in two ways. So we have we can do it in difference equations. This is kind of a Markov style thing. So that's we can be deterministic, so entirely based on the inputs you get the single output, or we can do it in a stochastic way. So we're doing a microsimulation model as well. The second thing we can do is we can put healthcare utilization on top of that based on our current understanding. So this is really important in terms of helping decision makers and strategy and planning, because we can look at the different projections at things like primary care level compared to community, compared to other things. And this is all very much a baseline forecast. So this is if we're to deliver the service into the future per person as we're currently doing, which obviously there are various reasons why that may or may not be valid. So first, looking at our population forecast, so we run the model starting at the year end September 2023. Some things to point out. Core segment 1, so the fewest diagnosed illness, the people with the fewest diagnosed conditions or the lowest multimorbidity, is the only one of the 5 that's set to decrease in size. Unfortunately, all the other ones are set to increase. I've just made a kind of a cognitive thing that we do. We say unfortunately. Remember, this is not necessarily a bad thing that people are living with illness, right? Because they may have otherwise not been living with illness historically. But it does mean, obviously, increased healthcare utilization. And the other big point to note here is that core segment 5, it's a very small proportion of the population. They're in terms of numbers of people, they use a lot of healthcare, and that's proportionally set to increase the most. That was step 1. We can now look at step 2. I appreciate that things are a bit small, but I'll just highlight what's going on here. So on the kind of vertical thing, what we've got is the different points of delivery. So for example, community, maternity, and going along the kind of horizontal, we have different metrics. So we can look at this in terms of activity, we can look at it in terms of cost, and we can look at it in terms of carbon cost as well. Some things to highlight. So community care has the highest proportional increase in all 3 actually, activity, cost, and carbon. And that's driven by the core segment 5 population. So you can see that red bar increasing such a high proportion. If you look at this compared to something like maternity, you can see there's not many core seg 5 people who are having babies, which kind of makes sense. So maternity is the only point of delivery not forecast to increase beyond your kind of usual scaling that you do, demographic scaling. And the third thing is to say that the total on across all points of delivery that we're looking at is vastly exceeding the ONS forecasts if we were to just look at a population or even at a demographic level. So this is the fact that health state is changing as well. Just to go through some of the use cases. So we are using this in the ICB. We're working with colleagues and definitely doing all of that integrated system stuff. So we've got financial forecasting that we're doing in the medium term, so that's 5 years. We're putting these things in. We're also looking at some of our carbon forecasts, so working with sustainability officers. And we've done some trust level baselining as well. And one other thing actually is what the keynote this morning talking about social care. We've got the new adult social care client level data flow involved. We've got social care forecasts as well. And we're kind of well aware of that level of thing that we're doing. And we've got some trust level baselining. So we've got this at ICB level, but there's no reason we can't pull the model down to subnational forecasting. So to summarize, we've got this framework for long-term forecasting. We're accounting for not just population demographic change, we're also looking at health state change, and this results in informative outputs that we can use at point of delivery level. What are we doing next? We're going to compare the different model approaches. So with that Health Foundation microsimulation model that we're looking at Health in 2040, Paul Seamer in the strategy unit also has a really interesting model. I've been speaking to someone yesterday who said that there's a separate model that York are doing that's really interesting. So if you know of any other long-term forecasting models in this space, I'd be really interested to hear, really happy to talk about that. We're going to look at doing different scenarios, and then we're going to continue to utilize this within BNSSG for strategic decisions and long-term planning. Final thing, just to say thank you. There's a blog post on real-world data science that is exactly the same as this talk, so if anything didn't make sense, we've written it up in words there that you can try and just say, yeah, thanks very much.
Thank you, Luke. We've got a few questions coming on Slido. just read them out if that's...
Yep.
Is there recording bias? Can everyone hear me? Is the recording bias present for conditions like hypertension and dementia, which are often not recorded until a serious health deterioration occurs and then suddenly multiple diagnoses appear on the patient record?
Yes, I think in a word. So that's one thing that all of these models currently really struggle with, is that we're looking at diagnosed illness. So obviously, point of diagnosis is there is known biases along IMD and things like that. So we can try and factor those in, but fundamentally we are looking at diagnosed illness. There's work we're doing on that. One of the interesting potential projects that we're going to do to try and combat this, because this is a kind of fundamental recording health data problem. We're going to try and collaborate with ALSPAC, so the Children of the 90s survey, so the longitudinal surveys project, to see how accurate our data is in terms of diagnosed conditions that we have on people now, but actually looking back right through to early life, because that's one thing that we really don't have is good long-term historic data.
What?
Can I just say, if you do want to move to another stream, to another talk, then please do that. I'm not going to cut off questions, and we'll keep the discussion going on a bit longer. But frankly, looking at the talks going ahead, why would you? Sorry.
What data do you use to calculate CMS?
So this is what is called within our ICB the system-wide data set, which is a wonderful collation of lots of different streams of record, but primarily in terms of CMS, this is from primary care data, but it's not solely from that.
What is included in the average cost, GP, drug costs, etc.?
Again, the costs are coming from the system-wide data set. This is a really valid and incredibly complex question. The way that we think about costs is, and activity as well, cost per unit, is very dependent on the situation, effectively. The charts that I was showing before, and looking up at aggregated up at GP level, what we've actually been doing when decision makers come with questions like this is we say, well, tell us what you want to be included, and we can drill down to that level within the data and forecast it based on that. So we can do bespoke versions depending on what question's being asked.
I'm interested in the flow across segments. Do you see certain diseases that cause patients to more rapidly increase from lower segments to higher ones? Is the flow across segments changing over time?
Yeah, two really good questions. Didn't have time to go into this talk about it, but yeah, unfortunately, that's one of the things that we are including in our model, but is a thing that we're seeing is that we're calling it kind of the transition rate degradation, but fundamentally, over even though it's only 3 or 4 years that we have good quality data for, people are moving faster between core segments. So on average, there's an increase in terms of levels of diagnosed illness. In terms of specific conditions that make people move between core segments, obviously, from a core seg 1 to core seg 4, even just having a single diagnosis can push you all the way up, which is often what it is if we see people making kind of a jump as such across core segments. But also as well, we do see it with a kind of combination of illnesses. But yeah, it's the thing that we're seeing, this changing of transition rates over time is something that we are seeing in BNSSG, and it is being seen elsewhere as well, and that is actually built into the model, is that the transition rates continuing on a train, and that's part of what we're going to do with our scenario analysis is, well, what if we could slow down people moving from healthier segments to less healthy segments, or what if we could change these different core segment transitions?
I think we've just got one last question.
Okay. What methods did you use for your population segmentation? Was it judgmental splits or a mathematical model?
So there is a paper that Rich Wood, who's my manager, wrote on this when the original 5 segments were decided, and it was actually a review of the different population segmentation methods that you can use, resulting fundamentally in the splits the cutoffs that we got to. They are, though, cutoffs based on kind of judgment. There wasn't a specific analytical reason for that, other than this really interesting feature that they have where this halving and doubling effect of going through them. So that is by design. We saw that in the data and we thought, oh, that's interesting. Let's apply the split so that feature is there.
Thank you very much, Luke. If we can give you just a thank you again. Thank you. So our next